G'day, my name's Stan Steindl. I'm a clinical psychologist at Psychology Consultants here in Brisbane, Australia, and also an adjunct associate professor at the Compassionate Mind Research Group, which is part of School of Psychology at the University of Queensland. I thought I might just present to you early shame and safeness memories and later depressive symptoms and safe affect, the mediating role of self-compassion, which is a brief presentation I delivered recently at the AACBT Conference here in Brisbane. Some memories never fade. They dwell at the edge of awareness, yet vivid and powerful. Some warm your heart so you never feel alone, and some reveal your deepest, darkest, loneliest shame. Some of our early memories are those of warmth and safeness, and these are thought to promote the development of the affiliative soothing system, which is linked to compassion and self-compassion, and also to regulate the threat system and negative affect states such as shame and depression. There's an established association between these positive emotional memories with well-being and protective effects for psychopathology such as depression. And in terms of early memories of shame, shame experiences may activate the threat system by creating a sense of threatened social self. The self is seen as vulnerable or defective, weak, unworthy, and others are seen as critical, judgmental, unavailable, and dangerous. Shame memories may increase the risk of negative emotions, such as depression, and negative beliefs about receiving compassion from oneself or others. And also shame memories may inhibit the development of the affiliative soothing system and one's ability to down-regulate threat and negative emotions through affiliative, affective, and motivational states, such as compassion. Shame memories may have traumatic qualities and may be central to our self-identity. Traumatic qualities and centrality of shame memories are associated with the severity of psychopathology. Compassion-focused therapy, of course, is a trans-theoretical psychotherapeutic approach designed to help people who are suffering from high levels of self-criticism and shame, and applicable to the treatment of a range of different presenting problems. The proposed mechanisms of change in CFT are to resolve fears of compassion and develop the competencies of compassion to alleviate shame and psychopathology. Fears of compassion mediate the relationship between shame memories and psychopathology, and this is now well established. No studies have tested the mediating effect of compassion on this relationship. So last year we embarked on a project, myself and an honours student, Alison Creed, in collaboration with Dr. Marcella Matush from the University of Coimbra, exploring early shame and safeness memories and later depressive symptoms and safe affect, and this mediating role of self-compassion. The aims of our study were twofold. Firstly, to investigate associations between shame memories, early memories of warmth and safeness, compassion across the three flows, for self, for others, and from others, and depressive symptoms and safe positive affect. The second aim was to investigate the mediator effects of the flows of compassion on the associations between early emotional memories and depressive symptoms and safe positive affect. We had 223 participants, 155 were females, and they were recruited from the general population, aged 17 to 70. 96 were undergraduate students from UQ and 127 were general community members. We used a range of questionnaires via an online survey, but firstly we did an exercise priming for a shame memory, in which we defined a shame memory and invited people to see if they could recall a time where they experienced that kind of shame. We then administered the impact of event scale revised to assess for the traumatic qualities of that shame memory, the centrality of event scale to assess the centrality of that shame memory, the early memories of warmth and safeness scale, compassionate engagement and action scales, the depression, anxiety and stress scale, and the types of positive affect scale. We found a number of important intercorrelations in amongst all of our variables. To begin with, we found significant correlations between shame memories and psychological outcomes. Shame memories were positively correlated with depression and negatively correlated with safe positive affect. We also found that early memories of warmth and safeness correlated significantly with psychological outcomes. Safe memories correlated in a negative direction with depression and correlated positively with safe positive affect. We also found a range of significant correlations between shame memories and compassion. Importantly, self-compassion correlated strongly across the shame memories variables. Self-compassion correlated negatively with the traumatic qualities of shame memories and the centrality of those shame memories. It's interesting to note that compassion for others did not correlate significantly with either traumatic qualities of shame memories or the centrality of those memories. Early memories of warmth and safeness correlated significantly with both self-compassion and receiving compassion from others. In terms of the relationships between compassion variables and psychological outcomes, we found that receiving compassion from others and self-compassion both correlated significantly and negatively with depression, and both correlated significantly positively with safe positive affect. However, we also found that self-compassion had the strongest correlation with psychological outcomes. We then went on to conduct path analyses, and these results indicated that self-compassion partially mediated the effect of the traumatic qualities of shame memories and early memories of warmth and safeness on depressive symptoms, fully mediated the effects of those traumatic qualities of shame memories on safe positive affect, and partially mediated the effects of early memories of warmth and safeness on safe positive affect. Centrality of shame memories was not a significant predictor of the compassion variables or the outcome variables. Our results suggest a range of important clinical implications. Firstly, we do need to assess for and directly target shame memories in treatment. For example, we may use exposure-based interventions targeting the traumatic qualities of shame memories. Alternatively, or as well, we might use approaches for meaning reattribution and cognitive restructuring, targeting the centrality of those shame memories. It does appear from these results that we need to work with fears of compassion and the competencies of compassion, developing the compassion itself. All three flows of compassion may be important, although most important are compassion from others and self-compassion. Specifically, developing competencies in self-compassion is important where high levels of shame memories and or low levels of early memories of warmth and safeness are part of the client presentation. Also, we need to find ways to directly target and increase safe positive affect. Cultivating self-compassion may be vital in helping to improve safe, positive affect, especially in the context of past shame. However, people with few early memories of warmth and safeness may need particular assistance to develop these feelings. If you'd like more information on the study that I've described, please be in touch. And thank you very much for listening.